Delighted to be here and having the opportunity to speak about something that actually has been near and dear to me, something I've spent a good part of my career involved in. And we'll touch on maybe a couple of those stories that Tanya had referred to. How many of you were drawn to this section because of the title? Did it appear a little controversial in terms of? Good. Then I hope that we address some of these and that you come away understanding what the intent was, and we'll wrap it up at the end and see if we accomplish that. Tanya did a great job of telling who MMA is, who we are, our mission, our vision, our values, making a difference in the moments that matter for your colleagues, your clients, and the communities. Our vision, world-class leader, revolutionizing the industry, and then our values of integrity, collaboration, passion, innovation, and accountability. Again, we're MMC, we're part of the MMC family, largest risk management firm in the United States with over 8,000 colleagues and 160 locations. And we do a lot of stuff. We cover a lot of waterfront. These are all of the areas, some of within the benefit space, but as Diana mentioned, we also do a fair amount as it relates to the business insurance side of the house. And in fact, a number of my colleagues who are here with me this morning, including myself, are also licensed not only on the benefit side, but also on the BI or business insurance or property and casualty side as well. So we have a fair amount of knowledge in that respect. So that's the last of the commercials for now. We'll go back. But this is a little bit about myself. Over 30 years of healthcare experience. My colleague Robert would say, why didn't you just tell the truth? And it's over 100 years of experience, but it sounds better at 30. I'm old, I know that, but I think 30 sounded better than 75. So let's get into the heart of the matter, shall we? On the history of corporate wellness. The father of workplace health was the Italian physician Bernardini Ramazzini. He was in the 1700s. He and I were classmates. And you know, he used to do a lot, you know, he used to go around to the companies and, you know, and do a lot of work with the workers and trying to figure out, you know, what caused them to get sick in the workplace. And in fact, did a lot of set the groundwork and did the first publications, formal publications as to why people get sick at work and things that could be done to solve that. A little known fact about him, though, was he was one of the first to use quinine. The cinchona tree, now it was kind of mentioned, my undergrad training was in pharmacy. I loved pharmacognosy, which is the division of pharmacy that looked at natural substances. So the cinchona tree, the bark of the cinchona tree, you can boil that down, and it's an aspirin-like derivative that comes out of that, part of which is quinine. He figured out that in Italy at the time, we were having a really big problem with malaria, and that quinine could be used for the treatment of malaria. And that was one of the areas of claim of fame that he had, in addition to hundreds of other things in terms of how to appropriately treat people who worked in the printing industry, lead, and that sort of thing like that. So he is the father of wellness and occupational medicine in particular. This is a slide, I really like it. I apologize that it's really hard to see. But there's so much in this that one of the things that we're going to do as we rework this presentation, figure out a way to get this information out so that everyone can see it. But what I wanted to point out was there are a lot of really interesting things that happen. So Bernardini here, we talked about him. We talked about the Industrial Revolution and the effect that it had. It was in 1810 that Robert Owen, who was a publisher and a researcher, looked into this and, you know, people are working, workers are working 20 hours a day in factories and sweatshops and that sort of thing like that. And he came up with the idea, well, rather than having 18 20-hour work days and people are getting hurt and that sort of, we really need to cut back on that And so he proposed a 10-hour workday. It worked. It helped reduce numbers, and had a positive effect. So that he then came back later and said, well, if that works, we really need to look at an 8-hour workday. And as part of that, his research said, well, there'll be 8 hours of work, 8 hours of recreation, and 8 hours of rest, recreation, and work. Those were the 3 8-hour periods. So really innovative. Ford Motor Company in 1914 was the first company, though, to actually take on the 8-hour workday for their employees as part of this. I want to see this next piece here. The Employee Retirement Act came out in 1974. During the 70s, there was a huge influx and change that took place as it related to workers' rights and all. 1979, and this is what's germane. So you say, okay, this is all really good stuff, but this is what's germane to our talk today. Wellness programs really kind of came out in the 1970s, between 75 and 80. And this was about the time I was in pharmacy school during this time, and I remember these programs coming out. And I did a rotation, not with Johnson & Johnson, but with another company that some of you may have heard of it. And this is going to be a question. If you know the answer to this one, then it tells me how old you are and if you're in my age group or not. But the major sponsor of the Houston Marathon, the first major sponsor of the Houston Marathon was who? A room of really young people. Okay. Tenneco. How many of you ever heard of Tenneco? Okay. Tenneco was a major sponsor. Tenneco was also the second or third company following Johnson & Johnson to roll out a program, a national program, spending millions, literally millions of dollars to take care of the health of their employees. Now, it came about as, in Johnson & Johnson's case, it came about because the publication, that sort of thing. In Tenneco's case, it came about as a result of the CEO at the time had a heart attack. He then became a big advocate of health and said, I'm going to take better care of my health. I want to do that for the employees, to the extent where he built a multi-million-dollar facility on the top of the parking garage, downtown Houston. And this facility was something like 45,000, 50,000 square feet, and it provided everything for the workers. Everything from, if you didn't have tennis shoes to work out, we gave you the tennis shoes. You didn't have socks, shoes, undergarments, whatever you needed to work out, we provided to you free of charge. All you had to do was just show up. So there were no excuses to do it. I'll come back and talk about why programs don't work, but I want to set the scene here. We then come down to some of the other things here that are also kind of interesting. The Healthy People 2000 program. Stephen Bunn was the CEO of Safeway Markets, supermarkets. Anyone heard of Safeway? Remember Safeway? Okay. He bought into this. He saw what was going on with Johnson & Johnson, with Tenneco, and a number of the other major companies. He says, I want my company to do this too. And so he bought into it. They started a program, but they said, we want to be able to demonstrate the efficacy of this. And so they started getting out talking about numbers of ROIs and that sort of thing like that. He published a paper in the Wall Street Journal in 2005. Subsequent to that, which was published, it became gospel in terms of the efficacy and the value of wellness programs. Subsequent to that, in 2009, the entire paper was debunked. All the claims in terms of these great ROIs and everything else were found to be false. So that's the significance here. That doesn't mean we don't do it, but the claims were wrong, and they were found to be wrong. 2010 Patient Protection Act came about. The Baker-Cutler Song Harvard study initially came out. Dr. Song, very highly regarded researcher in this area. Papers were produced that showed a 3-to-1 return on the investment. Unfortunately, 3 years later, Rand came out did a study looking at the initial data here, debunked it again. Found out that what was said was incorrect. It did not change the health or reduce costs as it related to these programs. And the issue was the cost. If you do this, we will save you money. You will have an ROI of 3-to-1, which was pitched. But I had people that came into my office, and during this time, I was the chief medical officer for Tenneco. People would come into my office and say, if you do this, you can get a 10-to-1 return, a 15-to-1 return. But I would say, okay, well, will you guarantee this? Don't give me a 15-to-1, don't give me a 10, give me a 2-to-1, give me a 3. How many of them, and I said, and if you'll do that, if you'll give me a guarantee on it, we'll pay you whatever it is. How many do you think ever did that? 0. Okay. So I wanted to set the stage for this in terms of, some of the history that's here. Why corporate wellness, right? I mean, at the end of the day, that's the purpose, that's the reason we're here, and we need to talk about that. A corporate wellness program, higher medical costs and greater health risks for individuals with unhealthy habits. We want to address these issues. The data suggests that lifestyle-related chronic diseases, and of the points on this slide, this is the most important, and I want you to concentrate on the 70%. I want you to remember that. I'm going to come back to it, but remember 70%. That lifestyle-related chronic diseases in the U.S. account for 70% of the nation's medical costs. And the same thing holds true when we talk about population health. And that the wellness programs are designed to support employees and sometimes their families as they adapt and sustain behaviors that reduce health risk and improve quality. That's the basis of this. This is why we do these things. All right, so what is the goal? The goal of a wellness program should be to reduce or eliminate the development of future cases. It's not to manage current ones. That's a key. It's not to manage your current cases. It's the future cases that we're looking at, we should focus on. And that's where the challenge comes in terms of managing these sort of things. I've got a couple of other case studies I want to share with you. Remember the ones I told about the RAND study and that sort of thing like that? These are two recent studies that were just published in the last couple years, 3 years. The first study, it came out of the Journal of American Medical Association, April of 2019. And it asked a very simple question. And that is, what is the effect of a multi-component workplace illness program on health and economic outcomes? And here's the findings. Now this looked at about 33,000 employees. Anybody familiar with the company BJ Warehouse or Wholesale Warehouse, okay, up in Chicago and that, right? This was their population. This was their people that they were looking at. And what they did was they split it up, and then they did a control study versus, the experimental group, and compared them over about 18-month period of time. What they found by looking at the two groups was that in the experimental group, those that they implemented a wellness program, there was an 8.3% more employees self-reported engaging in regular exercise, right? So they self-reported, yeah, I'm doing more. There was a 13.6% more employees who self-reported, and that's important, actively managing their weights. Now, there wasn't really a check on it, but this is what they reported. More importantly, though, by looking at actual claims data and the like, they found that at 18 months, there was no significance difference in the two groups as it related to clinical markers of health, healthcare spending, the utilization of programs, absenteeism, tenure, or job performance. All the things that we talk about why we want to have these programs. So, that was that finding. This is a conclusion, again, talking about what we just covered. So we then take a look at, well, in 2020, there was a follow-on study looking at a different population. And the question here was, how does a comprehensive workplace wellness program affect health beliefs, and medical use among university employees after 24 months? Now, they looked at about 5,000 randomized university employees. This was the University of Illinois. And this study is called the Illinois Workplace Study. It didn't look at the students, only employees. And in this case, what they found after 24 months was no significant difference in their biometrics, medical diagnoses, or medical use relative to the control group. The enrolled employees reported an increase in primary care physician relationships, however. So, if they didn't have a primary care before, there was a tendency for them to engage with one afterwards. And there was some improved health benefits, but statistically it wasn't that much, okay? So, starting to see a trend here? Okay. So our conclusion, or the conclusion of the study, workplace wellness programs improved health beliefs and increased self-reporting of primary care physician relationships, but did not significantly affect clinical outcomes.
Can I ask a question?
Sure.
When they're doing these studies, are they looking at just diagnoses or are they looking at severity?
No. What you look at in this case was they were looking for new onset. Now, severity is a different issue. I will get to that, okay? I promise you I will get there. So why have wellness programs historically failed to save money? Because they were sold on the ability to save money. Why have they not done what they claim to do? The primary reason, in my opinion, is it was a generic framework. Okay? These programs, when they were initially rolled out, were, if nothing else, they were generic in nature. They did not look at the specific risk factors that occurred within that population. Also, the offerings were too broad, and without consideration of demographic or population specificity. How many of you are aware of and I'll get to this, but the concept of population health? And that's the big thing now. You hear people talking about this, okay. I also have a master's in public health. I got that back in the 1700s, right after I finished with, but that was something we've been studying and looking at for well over 30, 40 years. Okay, the concept of it. The beauty of it now is with analytics, artificial intelligence, we're able to look at things, see things now that we couldn't necessarily appreciate before and process things faster. So it's a different world in that respect. But the demographics and population specificity, that piece has not occurred, and I'll get into that. Failure to establish measurable population-specific outcomes, KPIs. How many business people here operate a business without having some KPI, right? Right? You can't do it. But yet, we buy products, we buy services without measurable KPIs or outcomes all the time, particularly in the wellness field. Okay? So, and they have to be based upon health risk, and these risks have to be related specifically to your population. I'm kind of giving away some of the story, but we'll get there. Managing health costs through population health and claims analytics. All right, so I told you I would talk to you a little bit about population health. We're going to do that. And Robert, you didn't think I was going to get through all these slides, did you?
Yes.
No. So what is population health? Anyone care to give a definition of population health? Okay. Basically, and I'll read this definition to you. It's health outcomes of a group of individuals, and it includes the distribution of such outcomes within the group. I like to use a slightly different one. It's the intersection of demographics and epidemiology, where those come together within a group. and it tells you what the population specific to that group is. Now, these groups can be geographic populations, so we talk about national U.S. standards and a bell-shaped curve and that sort of thing like that. Or they can be small subpopulations within that group, in which case you can zoom in on them and it will tell you very important things about what's going on within that group that helps you in terms of figuring out how best to address those risks. All right, so how do you employ this? We've talked about that. Chronic diseases and healthcare risk. So by utilizing population health analytics, and this is US data across the country, okay? And it may differ by subgroups, but what we find is this is pretty interesting. The top 1% of people ranked by their healthcare expenses make up 21% of the total healthcare expenditures. How many of you knew that? The second, another important piece here is the top 5% of the population accounts for about 49% of total expenditures. The top 10% of the population for about 65% of total healthcare expenditures. So if we look at all of this and we say, okay, so what does this mean? If we look at the top 50% of the population ranked by their expenditures, healthcare expenditures, this top 50% makes up 97% of the overall healthcare expenditures within the country. It's a different way of looking at these numbers. But these are all, for the most part, driven because of chronic diseases. Now, the lower 50% account for about 3% of the total. So if you're going to focus on managing something, would it not make better sense to focus on managing this piece here than this, if you want to have the greater bang for the buck? And that's really what we're trying to underscore. So, population health, what would it look like? This is a slide that shows chronic diseases based upon age and age distribution. And if you recall, I said, well, you know, there are populations and subpopulations, okay? So if we're looking at this blue line right here represents what? Asthma, okay? So if I'm looking at a population, if I'm working with potential clients, say somebody in the fast food industry, you know, pick one, McDonald's, Jack in the Box, whatever. And I'm not talking about their corporate office, I'm talking about the folks who work in the stores. What's the average age of an employee within there? Would you agree they might be somewhere in that band of, say, 16 to, say, 24? Something like that maybe, right? All right, so if we look at that group, this band, let's pick it up at 15, and we go out to about 25, what are the risks that we see in that group? It's primarily going to be things like asthma, depression, anxiety, what is this one right here? And some early diabetes, right? Okay. So these are the risks for that population. You don't see really a lot here on the hypertensive piece. Osteoarthritis certainly isn't playing into that group. So the point that I'm trying to make here is that the risk can be, and they are, tied to age within a population. On the other hand, if we're talking about, let's say, a mature energy company, a mature manufacturing company, where the average age of their employees might be, let's say, in the 40s, 50s, somewhere in this area here, it's going to be a different makeup of challenges, right? So hypertension is a real player in this. Depression doesn't seem to have gone away. The issue here as it relates to asthma is still there. Diabetes now is really starting to pick up. You can see the curve picking up in here. And so the point that I'm trying to make is they're different populations, aren't they? So the issue of population assessment, you have to know your population. The first thing we do when we go in to talk to a potential client is, tell me the demographics about your company. What's the makeup of your company? And with that, we can tell you what your relative risks are. And with that, we can say, here's where your focus should be. Okay? A different approach as opposed to saying, well, we're going to pull something off the shelf, it's a plug and play, it's going to work. Particularly if our focus is on controlling costs. Now, if it's for creating an environment, changing culture, and I'll come back to that, that's a different issue. But if the issue is on cost, you have to focus there. It goes back to what we've said many times. If you can't measure it, you certainly can't manage it. This slide shows very similar sort of data. It's a little more robust, and then it goes into other areas more clearly in terms of cancer, osteoarthritis, and the like. But you can see the difference in terms of these age bands and what happens. Okay? Now, earlier on, I asked you to keep in mind the issue about 70%, did I not? So I like this slide because remember we said about the lower 50% having an effect on this 3%. All right, so here it is. And what I like about this slide is it does just such a great job of showing where wellness fits versus the other areas that really will do a better job of controlling your cost. Wellness sits down here in terms of, so you have a healthy individual here, and up on this other corner, you have high risk, high dollar, severe morbidity, mortality sort of issues, okay? And if you want to think of it a different way, when we were talking about the younger people, that might be that group here that don't have a lot of the risk factors. This can be an older population with more risk factors. And it shows how the way that you might want to approach managing this. Care prevention, traditional wellness programs can do just fine down in this group. And there's a place for it. But when you're in this upper corner, high risk, high cost, issues of care management, think disease management programs, utilization management, centers of excellence, those and interventional care. This is the place for those. And the tools you use here are different than the ones that are employed here. Okay. Have I converted any of you yet in terms of the way that you think about wellness? Okay. No? Okay, well, I'll keep trying. But again, we touch on the same issues here that we talked about before. This, again, kind of shows similar model presented in a different way. But again, the wellness piece down here, focusing on this 30%. If you add this 35% plus this 30 plus that 5%, what do you come up with? 70%, right? So the 70% piece here that we talk about that we really need to focus on, it's prevention, but it's active prevention, early identification, active prevention, interventional care, and then we get into this issue, it's, where's the best place to manage? So this area here, if you think things like cardiovascular disease, the horse is out of the barn. All right, they've had a stroke. Where's the best place for them to have that stroke managed? Or they have hypertension and they're experiencing renal disease. Where's the best place from an outcomes perspective and a cost negotiation standpoint? It's a different issue. They have it. At this point, they don't necessarily have the full-blown disease, but if you can catch it early here, you can control it ideally and blunt the curve, prevent them from moving north. I'm going to do this. All right. We talk about these programs, and I like using hypertension. So the value of this, think of it this way. If you identified this person in this area right here as a pre-hypertensive, and this is what most wellness programs focus here, you get them on the appropriate medication, management, and the other things, weight reduction, the curve may likely continue up, but instead of going up this way, it may go up this way, and you'll have a delta here, and that delta represents improvement in the quality of life, but also cost savings relative to that. Okay? Okay, so total population health at the center, wellness programs here, and then everything else within, and this is a corporate program of components that can make up a wellness environment. And when we think about that. So EAP, you know, is huge. We talk about mental health and the value of mental health within the workplace. It's off the chart. If COVID did nothing else, it showed the effects that you know, mental health in the workplace have. Prescription drugs, this is the fastest growing area actually. And we could spend another hour talking about this and how to control these costs, as well as centers of excellence in the other, okay? Let me pick up the pace a bit. Let's see. Employer can develop specific strategies through integrated claims analysis, looking at doing an analysis of what your actual claims are, a population analytics, and tailored wellness offerings. So you might say, okay, well, how do we do this? You know, who do we talk to? That sort of thing. So what is the goal? How does a company define success? The basic goal here is to manage your population risk. You know, you can't manage what you don't measure, right? Here is a tool, among others, that we use to help in that regard. It's an analytic tool. It allows for benchmarking. It allows for data warehouse. We're able to use your actual data, your population, to identify what your risks are, and then to provide with actionable methods by which to measure this. This is kind of what the dashboard would look like in terms of some of the analytics. Again, I apologize, we're running a little late, but it's there. This is all the various solutions that exist and potential solutions that exist, but if there's not a system by which to measure the outcomes and constantly measure whether they're working or not, you have various vendors that are providing products, but you have to be able to ask the question, is it working? Are we seeing the results that we're looking for? And setting the KPIs relative to each of these. Population, this is what the model should look like. Where you see you have well-being as part of the culture. This is an overall culture of health. And well-being encompasses all of this. But it's your disease management, your cancer, your care management, your centers of action, your utilization. These are the components that really drive your costs down from a cost perspective. So managing medical claim outliers, identify your high dollar catastrophic claims, review relevant medical codes for trends, review relevant pharmacy codes, again, because this is the fastest growing of the things that we're seeing now. Promote efficient coordinated care through your carrier, and then talk about developing centers of excellence and early establishment of outcome expectations. You have to know where you're going. Components of the of a corporate wellness program, again, socioeconomic issues, family issues, social types of employee or government policies, regulations, all of that has to be managed. And I apologize for going so fast, but I think I might have made it. Okay. If you build a culture of support, improving and maintaining a culture of what we care about our employees, that's what we want. Managing long-term healthcare costs, establishing employee loyalty, increasing the efficacy and efficiency, and producing and productivity on a daily basis, and becoming an attractive workplace, being a place that people want to be. We've covered a lot. Any questions that we can answer for you? Yes, ma'am.
I'm really interested in the components of the wellness programs that they are measuring.
Okay, who is measuring?
Well, where it's saying that it doesn't work, it doesn't work. Well, I would really like to know what exactly they're doing.
Yeah, well, and what I would do is point you, and that's why I cited the articles that I did. I have the actual articles in my briefcase. You could go to the Journal of American Medical Association, pull it, and it will provide you with that. But it basically goes through the health risk assessment, it goes through claims data, and it shows the issues of claims data, control group versus the experimental group. It's a very elegant study. It has been reviewed by by the most critical of the medical economics people that are out there. And this is, it's the thought. It's not to say those programs don't work, and that's why I was trying to get the message. It's not we're saying wellness programs don't work, but they were oversold, right? You know, people made promises about these programs doing things that they just couldn't do. And it became a matter of, well, how do I sell this? Well, I got to promise them they're going to get something. You got to get this, yeah. Well, if you do this, you're going to, well, how do you know?
It's almost like saying, I'm going to cure your illness, but I don't know what your
Illness is, yeah. And if you don't establish that end goal, so for example, on diabetes, with a model like this, if I know within a population that population has X number of diabetics who have the following factors, A1Cs are at a particular level, that sort of thing like that. I can assess the value of the disease management program two ways. Number one, the things that they promised that they were going to do, did they do them? Did the A1Cs come down to the levels that they promised that they were going to be? Number one. Number two, did they stay there? The most common rationale or reason I hear is people will say that they don't is because we don't have a control over what that individual does. Yeah, but you sold it on the illusion that you did. So that's part of the challenge of this field. But to answer your question, both of those studies are there. You should. I would recommend that you do.
Kendra, did you get your question answered? Okay, just making sure.
Okay. Thank you very much for the opportunity to speak with you today.